So thank you for joining the 8th Virtual Resident Education Lecture Series today. Today's topic is headache medicine. We have Dr. Daniel Weber, Adult Epilepsy Division Director at St. Louis University School of Medicine, joining us as our Q&A moderator today. And I'm also pleased to introduce our speaker for today, Dr. Teshamae Monteith. Dr. Monteith is an Associate Professor of Clinical Neurology at the University of Miami Miller School of Medicine. She is also the Chief of the Headache Division and directs the UCNS Headache Medicine Fellowship. Dr. Monteith is a co-recipient of the AAN's Palatucci Advocacy Leadership Award and Fellow of the AAN and the American Headache Society. She serves as an editorial advisor for the Brain and Life magazine and the American Migraine Foundation. Dr. Monteith, I will turn it over to you.
Thank you so much for that introduction. I'm so happy to be here. And as you learned, I have done quite a bit of advocacy, so you may hear that here and there tied into my talk every once in a while. So, headache is a huge problem worldwide. So it's really hard to get that within an hour, but my job is to be able to give you some tips to what to look for and to be systematic with the way you approach a patient that comes in with a complaint of headache. These are my disclosures. So the overall objectives are to discuss the diagnosis of primary versus secondary headache disorders. If you're not familiar with the International Classification of Headache Disorders 3, we'll discuss that a little bit. It's a very useful resource. We'll talk about some tips in eliciting headache, not just ruling out secondary headache, but as well as to distinguish between different types of primary headache disorders as well. And we'll talk a little bit about diagnostic testing, when to do so, what the indications are. We'll focus on some lesser known headache disorders like the trigeminal autonomic cephalgias. And hopefully you'll come away with this talk having a good sense of how to treat migraine, which will be a very common, no matter what type of neurologist you become, your patients will have migraine, and it's very useful to know how to integrate the different treatment options. So migraine is common, as I mentioned. It doesn't matter if you become a stroke doctor, if you're specialized in epilepsy, Parkinson's disease, you're gonna see migraine. And migraine is just under back pain, the most common reason that a neurologist is consulted. So it's really helpful to understand headache disorders in general, and certainly migraine. As I mentioned, migraine is common. 1 billion individuals worldwide is estimated to have migraine. So about 38 to 50 million individuals within the United States alone. It's more common in women than in men. Migraine's peak prevalence is when individuals are most productive. So in your 30s and 40s, you see that peak prevalence. And as we said, migraine is a highly disabling disorder. So the second leading cause of disability, just under low back pain. So a really common problem, a reason to go to the emergency room, to be consulted by a neurologist. It's an expensive disorder. And a lot of our neurologists actually have migraine. If you're a headache specialist, you're really likely to have migraine. But certainly as neurologists, both men and women, the prevalence of migraine is much higher than the general population. So there's several types of headaches, as we mentioned. If you can separate it out between primary and secondary disorders, it's very useful. Broadly speaking, a secondary headache is a type of headache associated with, temporally associated with some disturbance in the body. So that could be an infectious cause, that could be a hemorrhagic cause, that could be a rheumatologic cause, ophthalmologic cause, a systemic disorder, or other types. It's really important to be able to diagnose these secondary headaches, because when you address the secondary cause, the headache will be, for the most part, resolved. So this is the International Classification of Headache Disorders, now in its 3rd edition. So very useful to just go on this. It's a free access to anyone. Be able to just kind of get a sense of how these headaches are teased out. So first is the primary headaches, and that's what we generally see in clinic. So migraine, we'll talk about all the different migraine subtypes, but migraine, there's tension type headache is actually more common than migraine, but it's pretty rare that a person comes to you and you're going to diagnose that person with tension type headache. So if someone's coming to you and they have bilateral headache that's pressing but bothersome and interfering with their life to the point that they bring it up, really try and assess those associated features to determine whether that could just be migraine. There are other primary headache disorders that we'll discuss. And then, of course, the secondary headache disorders vary in etiologies, and we'll discuss a few of those. And then there's the neuropathies and facial pains that we will also discuss. And then what is the appendix? The appendix is an area that is still under investigation. So there are a number of proposed diagnostic criteria still under investigation, like vestibular migraine, for example, that still needs more research before we use it and before it becomes validated. It's really important to do that research so that we're all speaking in the same language. So let's start with secondary headache disorders. So SNOOP is a nice acronym coined by David Dodick, and it's a way of thinking about systematically when you're approaching these patients, and you should always be thinking when you first see a patient, could this be a secondary headache disorder? So what are some warning signs? Some warning signs include fever, weight loss, secondary risk factors like HIV and cancer. Neurologic symptoms or signs can be very concerning, of course, in some primary headache disorders like hemiplegic migraine. That could be part of the migraine, but you don't know that the first time you meet that patient. Abrupt onset is very important, suggesting Thunderclap Headache, which has its own differential, which we'll discuss. Older patients, you have to think about things like glaucoma, giant cell arteritis, cardiac cephalgia. What is cardiac cephalgia? That is when an individual has a cardiac disease and it's presenting as headache, and usually this is exertional. The treatment is not a triptan. As a matter of fact, a triptan could make that patient worse because of vasoconstriction. So previous headache history, if there's a change or a new pattern or difference or progressive change, as we mentioned, primary headache is very common. And so even individuals with migraine may have secondary headache. And so if that pattern changes, you may want to think about secondary cause. Postural factors, so CSF leak is a classic example, orthostatic headache. Important that postural headache can sometimes be lost with time, and it might be much harder to diagnose that patient. So it's really helpful to get that initial diagnosis of orthostatic headache. Precipitated by Valsalva, so Chiari malformations, classic cough can trigger severe headache, or can be a sign of a space-occupying lesion. And then there are other things like brainstem symptoms that's suggesting idiopathic intracranial hypertension, supposed tinnitus, for example. And then pregnancy. There are a number of secondary headache disorders during pregnancy. Obviously, primary headache can also occur. And so just to remind ourselves, older patient, new onset headache, never had headaches before in my life. Rare, maybe ibuprofen once every 5 years. Now I have a severe headache, older individual. You want to think about that diagnostic possibility of temporal arteritis, because the patient can go blind. So not just the headache is important, but the secondary complications. We know that temporal arteritis is not just associated with blindness, but also can be associated with ischemic stroke, for example. So being able to have that level of concern is really important when you're approaching these patients. And of course, papilledema, you always want to do a complete neurologic exam and a focused headache examination to make sure that there are not secondary causes that can be very obvious. So we mentioned thunderclap headache, abrupt onset headache, severe maximum intensity within less than a minute. There are vascular causes, and then there are non-vascular causes. Some of the vascular causes can be obviously very concerning. Subarachnoid hemorrhage can lead to death. There can be patients that have aneurysmal thrombosis or expansion. Reversible cerebral vasoconstriction syndrome can often present with thunderclap headache. So these are things that you really want to be concerned about. But there's some non-vascular causes. Even CSF leaks can present with thunderclap headache, colloid cysts of the third ventricle, meningitis. And then there's some more benign causes like primary cough, sexual and exertional headache, as well as just a primary thunderclap headache, which before you get that diagnosis, you really want to make sure that there's not something more insidious such as RCVS. So this is a case. This is a woman, 30 years old, history of infrequent headaches, presents with severe throbbing headache, 10 out of 10, peak severity. She does have severe photophobia. She does have vomiting, some myalgias and nausea. And she presented to another hospital and was told that she had migraine, was given some medications. There was no relief. When she came to us, we evaluated her further and we were able to determine that she did have some papilledema. So that was concerning. She had a lumbar puncture after brain imaging and her opening pressure was elevated. So this patient had a brain imaging and there were some abnormalities on her brain imaging that suggest high pressure. So there are a number of potential radiographic findings of high pressure that you should be aware of. Flattening of the globes, tortuous optic nerve, perioptic fluid, empty cellular, classic signs of idiopathic intracranial hypertension. So this patient was discharged on acetazolamide. On follow-up, her papilledema actually improved. The whooshing sounds, auditory whooshing sounds can be present, ringing the ears can be present. Patients can sometimes even be ataxic. So really important to get this because as we mentioned, patients can go blind. But it needs to be more than treating the patient. You have to get that history. And in her case, she did gain weight during the pandemic. This may be a story that you hear more often because of inactivity and social distancing and not going to the gym. So ask that question of whether there was weight gain. If the individual is able to lose 6 to 10% of their weight, this may be able to target the symptoms and lead to resolution of headache as well as optic nerve findings. But in the meantime, diuretics are a treatment of choice. Acetazolamide, topiramate can be helpful because of the side effect of weight loss. You can use that as a therapeutic advantage. Some patients need to go on to have VP shunts, unfortunately, and the role of stenting is still under investigation, but may be appropriate in the right patient. Endocrinopathies, there are a number of other comorbidities, metabolic comorbidities that can be associated. Medications are a classic example, tetracyclines, doxycyclines. So getting that great history is really important for a patient to get that diagnosis, but weight loss is gold standard. And then what about the reverse? Low pressure headaches or CSF leaks, oftentimes due to spinal leaks. There are a number of classic imaging findings. Of course, the postural headache, you want to get a history of a potential back procedure. Was there heavy lifting? Even trivial trauma can do it. I had a patient that interestingly had an epidural when she was having her baby. 2 to 3, she never felt well, very mild dizziness. She always had migraine. The migraine wasn't necessarily more frequent, but that she had this kind of intermittent dizziness. And she was lifting and developed a really severe headache that then became a postural headache. She had a blood patch and her headaches improved, and that kind of dizziness sensation that she had had for years after her epidural actually also improved. So for CSF leaks, there's indication of brain sagging, so low-lying tonsils. There may be enlargement of the pituitary gland. That is also important to look for. If you get a contrast study, you may also find some enhancement of the dura. Post-traumatic headaches are very common. It could be due to accidents. It could be due to blast exposure in the military. It can be due to sports. It could be due to violence or even domestic violence, unfortunately, the pediatric age range, as well as in older individuals. So it's important to ask about post-traumatic headache because it's very common. And there's diagnostic criteria for post-traumatic headache. Generally, you like to see the headache happen within a week of the injury. Some patients can have a delayed onset of headache that's still under investigation, but we know that there's biology to that experience. Generally speaking, the good news is that most patients have a benefit and resolution of headache over time, but there are some patients that go on to have persistent headache. And as you can imagine, there are a number of brain changes that are occurring associated with traumatic brain injury that can predispose individuals to persistent post-traumatic headache. And this was animal study showing that in the trigeminal ganglion, this was a model of mild traumatic brain injury, that this is fluorescence for CGRP, calcitonin gene-related peptide, which is associated with severe migraine attacks. There was increased staining after the mild traumatic brain injury. So this is just one neuropeptide that might be important in the biology of traumatic brain injury and post-traumatic headache. And so as we mentioned, the good news is that over time, there can be resolution of symptoms. And this was a nice imaging study showing, in addition, there can be resolution of functional changes in the brain. Let's talk a little bit more about primary headache. It's important to have a good approach when you're approaching someone with the complaint of headache in clinic. First, is this their new onset headache? Is this a worsening of pre-existing headache? Had that individual had chronic daily headache in the past? What are the preceding events associated with this headache in terms of injury, illness, major life event, traumatic factors, other physiological changes that are going on? For example, heavy menstrual cycle or changes in sleep, occupational factors. And then you want to find out whether this is, of course, acute, subacute, or chronic. You want to find out about total headache days, days with any headache. You want to know whether the duration is less than 4 hours, greater than 4 hours, or even continuous. The pattern of the headache, the associated symptoms of the headache are very important, including atypical symptoms. And then there's something called migraine markers, which is just that nice icing on the cake. And this is a number of things like ice cream headache, motion sickness, that gives you a sense that this patient may have at least a biology of migraine if they don't meet all these criteria. So it's very useful to be systematic in approaching patients, including assessing premonitory phases and postdromal phases. Once you diagnose a patient with primary headache, you have to decide whether this patient first has primary headache, whether imaging is indicated. Oftentimes in our neurology clinics, patients come and they've already had imaging. What are indications for imaging? Head injuries, older age, new onset, changing pattern, abnormal neurologic examination, changing headache pattern is a really important one. And, as we mentioned, it's not just migraine. Cluster headache is, while a more rare disorder occurring in 1 in 1,000 is not uncommon, is something that you will and can see in clinic. There's often diagnostic delay, average about 7 years till a cluster patient gets that diagnosis. Cluster headache is considered one of the most severe types of headaches and certain pain known to man, worse than childbirth and even gunshot wounds, some people have noted. So it's important to try and, broadly speaking, be able to separate out the different types of primary headache disorders. Migraine is generally long-lasting, hours to days. Cluster headache is generally shorter lasting, minutes to hours, up to 3 hours, and can occur up to 8 times per day on average. Paroxysmal hemicrania is a shorter lasting headache, typically occurring about 20 minutes. And there's the hemicrania continua, which is a continuous headache, and it's diagnosed with indomethacin, versus the trigeminal neuralgias. This is electrical shooting pains that last seconds and is associated with cutaneous and thermal mechanical triggers, versus primary stabbing headache, which is often unilateral, can be variable, and is often comorbid with migraine. So this is a really important chart to really try and hone in on. And even with the trigeminal autonomic cephalgias, they're much shorter lasting headache syndromes called SUNCT and SUNA. And there are groups of stabs of pain and different patterns of pain that it's nice if you're able to elicit this to be able to appreciate the phenotype of individuals. Migraine is, again, most common disorder that you're going to see in clinic. And generally speaking, it's considered a genetic disorder with environmental factors. There are a number of susceptibility to having migraine, and there's no good test. The test is really the neurologist being able to elicit that history. There are a few Mendelian genes that are associated with hemiplegic migraine, but by and large, the majority of migraine is thought to be polygenetic. So we talked about getting a good history. Part of that getting a good history is not just assessing the headache, the duration and associated symptoms of the headache, but also being able to understand the overall clinical features of migraine, including the premonitory symptoms, which is the first sign that a migraine is occurring. This can happen hours to days before an actual migraine attack, and is very useful in being able to help patients prepare for their migraine attack. At the postdromal phase is a time where headache is gone, but you still feel fatigued and washed out. It's really important to recognize that the disability is the totality of the migraine and not just the headache phase. And of course, there's migraine with and without aura. It's important to understand aura is not just visual, even though visual is most common. There are many patients that present to the emergency room, some with very little headache and with just an aura. Could be speech, could be sensory, could be weakness, could be vertigo, especially in older age, and sometimes get misdiagnosed as having TIA or a stroke, and sometimes resulting in thrombolytics, even though generally speaking, thrombolytics, even in the setting of a misdiagnosis of migraine, generally does not cause harm. It's important to get that diagnosis because patients can then get treated appropriately. So migraine with aura differences from ischemic attacks includes the slow progression of symptoms. And so oftentimes I ask patients about the visual disturbances, the progression of the symptoms. Did it first start in your face, then travel in your arm? Was there tingling, positive symptoms associated with your episodes? And this was just Serene Branson. She had an aphasic aura, and this was while she was reporting, and it gave the world a real good sense of migraine and the complexity of migraine. If you have not seen this video, please go ahead and check it out on YouTube. You get a real good sense of what it sounds like to be experiencing migraine. And of course, there is chronic migraine, which is different from episodic migraine. Chronic migraine is associated with more disability, 15 headache days out of the month or more. 8 of those days meet criteria for migraine. This has been going on for at least 3 months. Important to get that diagnosis, important to be sensitive to the headache days and headache-free days, because many times patients want to report the more severe episodes, the 8 days that is occurring per month, and they're not telling you about the milder pain. And if you get the whole history, your treatment approach may be different, and certainly a greater recognition of the disability as well as the comorbidities associated with chronic migraine. It's important to assess patients for medication overuse headache. Medication overuse headache occurs in about half of the individuals with chronic migraine. Medication overuse headache is defined as the use of simple analgesics at least 15 days out of the month, combination analgesics or triptans or opiates over 10 days of the month. So important to get that. If that's been going on for over 3 months in the setting of chronic migraine, you should be suspicious for medication overuse headache. Just because an individual is overusing analgesics, and we use the term overusing analgesics, which might not be the most patient-friendly way to describe it, simply because patients are treating because they're suffering. But that gives you a therapeutic opportunity to consider prophylactic therapies, which can be pharmacologic and non-pharmacologic. So, the pathophysiology of migraine is exceedingly complex, and that could be a whole seminar. But what's important to know is that migraine is more than just a headache. It's a complexity of symptoms, and that it is not a vascular disorder. It's more appropriate to consider it as a neurovascular disorder in which there are parts of the brain that are being activated during acute migraine attacks. And there may be changes in functional connectivity that's been shown in multiple studies in patients that have migraine. So there's something different about the migraine brain than individuals without migraine. And there are a number of structures based on functional imaging studies that show activation, such as the hypothalamus, which we discussed some of the premonitory symptoms, and we know that the localization of many of these premonitory symptoms suggests that the hypothalamus is at least an early player in migraine pathogenesis. Calcitonin gene-related peptide is one important target for migraine therapeutics. We know that CGRP, calcitonin related, this is my green light, sorry. Calcitonin gene-related peptide is released during acute migraine attacks and is persistently elevated in individuals with chronic migraine. There have been a number of therapeutics, as we mentioned, that can be targeted. We'll talk about that in a later slide. So what is the evidence that calcitonin gene-related peptide is important for migraine? Well, there have been infusion studies suggesting that if you infuse CGRP, that it can be associated with acute migraine attacks. And normalization of CGRP levels is associated with pain relief with sumatriptan. We talked about the CGRP that can be persistently elevated in patients with chronic migraine. And so, as we mentioned, migraine is complex. There are central mechanisms that are involved. There are peripheral mechanisms such as the throbbing pain. There's muscle tenderness that occurs. We believe that there's thalamic activation that's occurring, allowing for higher pain pathways that are important for migraine. So a lot is going on, and this allows for different ways of targeting the brain and to get a multidisciplinary approach for patients. So this is Jennifer. She's 26 years old. She has a history of about 12 migraine days. It's been going on for six months. She does have hypertension, is taking lisinopril, and has anxiety, and is using venlafaxine. She has a MIDAS of 30. MIDAS is a disability assessment. So anyone that has 21 or greater has grade 4 disability and certainly would benefit from prophylactic therapies. So, when we have these patients, it's important to assess them for risk factors for chronic migraine. You may want to see a patient with a number of risk factors more frequent in clinic. So a high attack frequency, nausea, allodynia, the sensation that you touch your skin and that sensation of discomfort. It's what we call allodynia, obesity, pain disorders, depression, anxiety. There are a number of risk factors for chronic migraine. Insomnia is a very important one. It's important to also integrate social determinants of health when you're approaching patients. Social determinants of health are important for disease states, neurologic or other causes. So asking about economic instability, environmental factors, social factors are very important in determining of the overall care for your patient. So migraine treatment options, there are a number of pharmacological and non-pharmacological treatment options. We mentioned antihypertensive medications, so beta blockers are first-line therapeutics for patients, anticonvulsants, topiramate, valproate, Botox injections if the patient has chronic migraine, CGRP monoclonal antibodies, targeting the receptor or the peptide, as well as the new small molecule antagonists known as the GPANs. Acute therapies, if patients have moderate to severe attacks and do not have contraindications to triptan, should be on a triptan. Non-steroidal anti-inflammatories can also be used. GPANs are nice, especially in individuals that have high loads of vascular risk factors. So So that is also something to consider, as well as lasmiditan. Non-pharmacological interventions include psychological interventions like cognitive behavioral therapy, relaxation, biofeedback. There are a number of neuromodulation devices, which we'll discuss. Lifestyle factors are always important to discuss with patients and to be able to elicit these to see whether there are any reversible lifestyle factors that can be addressed. And just a reminder that in terms of separating out the different primary headache disorders, triggers are a nice way to do it. So menstruation, for example, sensory overload, so stimulation of a computer, bright lights, loud sounds. There are a number of triggers that can separate primary headaches and specifically migraine. The American Academy of Neurology has a headache measurement set published in 2019. Really important to take a look at that and to be able to document a good evaluation. If you have great documentation, it really helps improving the communication and the care plan for patients. That includes documenting the migraine frequency, the modifiable risk factors, the presence of medication overuse headache, whether it's present or not. Acute therapies, we mentioned some of this for migraine, and this is a partnership with your patient in terms of trying to figure out what works best. And again, documentation is really helpful. Many patients come in and they don't recall what they've been on the past. So counseling patients is really of utmost importance. Of the prophylactic therapies, one way of approaching which prophylactic therapy to start a patient on is by their comorbidities. So if a patient has anxiety or depression, you may want to consider an antidepressant. If a patient has obesity, you may want to avoid valproate, or if a patient is in childbearing age, you may definitely want to avoid valproate. And having said that, it's important to have preconception counseling when you're approaching patients and deciding a woman with migraine, because some of these drugs can have teratogenic effects. And so safety is always of utmost importance. And like we said, the partnership, hearing your patient, understanding what their concerns are. There can be a number of concerns that they have, including costs, which can be a problem, especially with the newer generation medications. And so this, I like looking at this. This is just showing you the different sizes, relative sizes of the monoclonal antibody versus a small molecule GPANs, which can be used as a prophylactic therapy as well as an abortive therapy, depending on which one you use. So small molecules likely to get into the brain, cross the blood-brain barrier, versus monoclonal antibodies, very large and less likely to get into the brain. So calcitonin gene-related peptide is found throughout the central nervous system, and there are a number of potential targets that are important, we think are important for the migraine pathway. There are 4 monoclonal antibodies to the CGRP pathway. These are subcutaneous injections with the exception of eptinazumab, which is an intravenous infusion every 3 months. So all patients may have hypersensitivity reactions. Injection site reactions are very common with the subcutaneous injections. Arenumab has a small risk of constipation and worsening hypertension. The responder rates for the CGRP monoclonal antibodies, it's really hard to compare these studies because the study design were different, the patient populations were different, but what's important is that responder rates were high and side effect profiles were generally very low. So on botulinum toxin A, FDA approved in 2010, so a lot of experience with it and very effective for patients with chronic migraine. It's something that you as residents should be able to learn how to do. You can do that at your local residency programs. You can participate in the chronic migraine sessions at the American Academy of Neurology. It's really a lot of fun to be able to do some procedures and be hands-on, and there's a therapeutic bond that occurs when treating patients with injectables. Botulinum toxin A, while effective, is not the only procedure available for patients with migraine. Occipital nerve blocks can be used. Great occipital nerve blocks are very effective for cluster headache and very effective for occipital neuralgia and can be helpful for patients with migraine. Spinopalatine ganglion blocks can also be useful for patients with both migraine as well as cluster headache. Although the evidence is less for that, it can be very useful as part of overall care. Neuromodulation devices for migraine are very cool, and they just keep adding them to the list. So these are non-invasive ways to both treat acutely as well as prophylactically, and they vary in terms of which ones can be used in terms of acute therapies versus preventive therapies. So transcutaneous supraorbital neurostimulation can be used for abortive therapy as well as 20 minutes a day for preventive therapy. There are a number of other things like non-invasive vagal nerve stimulation that is actually FDA approved or FDA cleared, I should say, for cluster headache, but can also be used for migraine. Remote electrical neuromodulation can be used for an abortive therapy for patients with migraine. And that's a really cool remote stimulation, which can be safe and effective as part of overall care. So we mentioned a little bit about the behavioral therapies. It's important to integrate behavioral therapies in patients that have migraine. Behavioral therapies, depending on your patient, can be very effective. We know in the pediatric age range, there's been studies showing cognitive behavioral therapy in combination with amitriptyline was superior to education plus amitriptyline. And so it's nice to have different options for patients with primary headache. What other primary headache disorders exist? I want you to go to the International Classifications of Headache Disorders, but we'll go through a few of these things. So there's primary headache, exercise headache. So these are individuals, as it sounds, they exercise, they get a severe headache, and this could vary in phenotype, and you have to rule out secondary causes, vascular causes. There was studies showing a high association with internal jugular venous valve incompetence, which is kind of interesting. Once you've ruled out secondary causes that can be of concern, patients can be pre-treated with 30 minutes prior to exercise or prophylactically with beta blockers. Primary cough headache, again, you must rule out secondary causes. This is a person that coughs and can have headache. There are no intracranial abnormalities. Valsalva can also trigger these headaches. And generally, this is self-limiting, which is important. Patients have sudden headache that's usually short-lived. Primary cough headache is actually quite common in pulmonary clinics, less so in neurology clinics, but important to be able to treat these patients. These patients may also respond to indomethacin. Primary headache associated with sexual activity, again, ruling out secondary causes like posterior fossa abnormalities, vascular abnormalities. RCVS can sometimes present with sexual activity. So important to be able to assess this. Once you've assessed this and ruled out secondary causes, pre-treating with indomethacin may be of benefit in these individuals. And again, the nice thing is that this is often self-limiting. Nummular headache is a coin-shaped headache that an individual has. It's a continuous headache, can be treated with botulinum toxin A, or other medications. And it's very interesting because it's coin-shaped. The pathophysiology of nummular headache is not fully understood. Hypnic headache, this is generally a headache in a much older individual, 50 years, new onset headache. Headache is happening at night and resolved when they wake up. They should not have cranial autonomic symptoms, which makes you think about cluster headache or trigeminal autonomic cephalgia. Hypnic headache can be treated with caffeine, and which is kind of interesting. Indomethacin, lithium can also be used for treatment of hypnic headache. Cranial neuralgias and facial pain. So there are a number of cranial neuralgias and facial pain disorders that, that can present to clinic. Trigeminal neuralgia is the most common type. Trigeminal neuralgia can be classic or it can be secondary. There can be an idiopathic version. For the classic trigeminal neuralgia, you have determined that there is a neurovascular compression. Superior cerebellar artery is the most common artery involved with this neurovascular compression. Medications can be helpful, whether it's classic or idiopathic. Some patients in which you've determined that there's neurovascular compression that are refractory to medications may benefit from decompressive surgery. There are other types of neuralgias like glossopharyngeal neuralgia. Occipital neuralgia can be very common in clinic. For the trigeminal neuralgia, there was a publication that showed that there are differences in classes versus symptomatic. You want to be able to determine whether someone has a symptomatic type of trigeminal neuralgia because that is a secondary disorder. But if you look in the clear versus the dark, the symptomatic trigeminal neuralgia, it generally is younger individuals versus classic trigeminal neuralgia tends to be older individuals. The symptomatic trigeminal neuralgias, there may be a bilateral component versus unilateral for the classic trigeminal neuralgia. There can be more commonly sensory deficits with patients with symptomatic trigeminal neuralgia, and abnormal trigeminal reflexes are actually far more common and a distinguishing factor in patients with symptomatic trigeminal neuralgia. Oxcarbazepine can be very useful and better tolerated, although level A evidence supports carbamazepine. So I think we're going to be running out of time, so I just want to wrap this up. Headache is really common. It's common in your neurologic clinics. I don't care if you go into neuromuscular disorders, if you go into stroke, or if you go into epilepsy, you're going to see headache disorders. You're certainly going to see migraine. It's fun to be able to get patients better. You want to look at the possibility of secondary headaches, understand the international classification of headache disorders, how it's designed, be able to have a complete assessment of patients. If you have a way of eliciting a history and you're systematic about that, you're unlikely to miss things. Important to have risk factors, in particular risk factors for progressions, comorbidities that are commonly associated with migraine. There are non-pharmacological and pharmacological therapies. Have that conversation with your patients. Some patients that are refractory to outpatient approaches may benefit from multidisciplinary approaches, which include the aid of psychologists, nutritionists, even inpatient management for migraine headache, for example. Difficult to treat migraine requires reconsideration of the diagnosis, but oftentimes reconsideration of the treatment plan. Thank you for your time.
Thank you for that run through of all things headache. There's a lot of information packed into a little bit of time. There is a question that came across in the Q&A in regards to IAH patients, or IAH referrals, I guess. For a patient that has, I assume, an incidentally seen empty cella on their imaging, would you automatically do a diagnostic LP on those patients to see if they have increased intracerebral pressure? Would you send them to ophthalmology for a more formal visual field and fundoscopic examination?
Yeah, so that's a great question. We see a lot of patients with empty cella. Some of these patients don't even have headache, right? So empty cella, it can just be an incidental finding without headache. So I think you really need to have approach. We talked about being consistent with approaching patients with headache. So there has to be some warning signs: worsening headache, new onset headache, ringing in the ears, weight gain, whooshing sounds in the ears, sometimes diplopia. You may not have all that. You can do a fundoscopic exam yourself. Sometimes, some people don't always feel very comfortable with the fundoscopic exam, but if a patient's presenting with headache, you find that the empty cella sign and you're suspicious for idiopathic intracranial hypertension, I think it definitely makes sense to send that patient to ophthalmology. Make sure that there's no papilledema. If you don't have papilledema, you have more time to then decide whether this is truly idiopathic intracranial hypertension, whether that patient would benefit from a lumbar puncture. And some patients, may not want that lumbar puncture. So if your suspicion is still high, you can try and treat that patient with something like topiramate. You can look for secondary causes like anemia or other or some endocrinopathies that can be associated with it. You can tell that patient if the patient has gained weight to try and lose weight, because the treatment, as we said, the gold standard is weight loss. And so partnering with the patient, making sure there's good follow-up is really important. But I think most of us neurologists would feel very reassured when we know that there's not papilledema, and keeping in mind that there are other types of processes that can cause increased intracranial pressure.
Is there any explanation or reason in the articles on why that the IV option is Q3 months instead of Q month, despite the fact that the half-life is very similar amongst all those medications?
Yeah, that's a good question. So with fremanezumab, we didn't get to mention that, but fremanezumab is another CGRP inhibitor. It blocks the peptide, and that can also be every 3 months if you give 3 times the dose. So it depends on dosing. And once the patient gets to steady state, then actually the monoclonal antibodies last 5 months in the system. So I don't know the answer to that and whether it has anything to do with the infusion, but eptinezumab is not the only CGRP monoclonal antibody that is every 3 months.
Given the now wide world of options you have to treat someone with migraines, do you have a particular go-to, this is the first one I'm going to choose in my uncomplicated migraineur, or are there certain clinical things that tip you one direction or the other for either abortive or preventative therapies? Yeah,
so good question. A lot of residents, I think you must have gotten that from one of the residents, because everyone wants to know about the go-to. And the American Academy of Neurology has come up with evidence-based guidelines, right? These are kind of old, and I believe that they're getting ready to update it from 2012. So it really depends on the patient and what is the frequency of migraine, what is the level of disability of migraine. We talked a little bit about having disability assessments. So if a patient's losing a lot of time on work and they have let's say they have high frequency migraine attacks, so about 10 days per month, you have less time to fiddle around, right? So you want higher level of evidence. And of course, safety is a concern. If a patient has infrequent migraines, let's say about, everything is relative, but let's say about four to 5 days per month, and they're responsive to their abortive therapies, you may have, and they're not missing work, the attacks are severe, but they're not missing work, you may have some time to say, well, you want to try a nutraceutical approach. They want to try something that might have less evidence. That's okay, because the impact of making that being wrong is less. And so for patients that have high disability, I go for the first line treatments, topiramate, valproate. I try not to use as much, but in the appropriate patient, the thin, tall man, why not? And in some phenotypes of migraine, we didn't get time to talk about all the different subtypes, but it might be an appropriate thing. And of course, unfortunately, we're living in the world of insurance where we have step therapy. There are some patients I want to put them right away on CGRP inhibitors because of their comorbidities or their frequency. And unfortunately, you have to try things with less evidence.
That was my next question is, have you run into trouble with insurance companies on getting access to the new medications, and what sort of hurdles do you have to overcome to get that access? Are there specific medications that must be failed? Obviously, it's going to be specific to specific insurances, but is there any common trend you're seeing?
Generally speaking, so the general common trend is once things become integrated, a part of clinical care. There's a time with onabotulinum toxin A, there was a lot of anxiety about getting that approved. And now it seems like with our eyes closed, we're able to get that approved with, so the first thing, the power you have as a physician is your documentation. So it's the biggest thing I see that, this basic thing, headache days, migraine days, level of disability, duration, they actually look for these things. Those are things that, reviewers without a medical background can just quickly look to see if you have that. So if you have that, and then you have the prior preventives use, it's much easier to get the approval. So documentation is really important. But generally speaking, many of these newer generation medications require you to have tried 2 or 3 standard medications, which could be anticonvulsants, blood pressure medicines, or antidepressants. And sometimes they're picky. You could have put a patient on nortriptyline, and they're like, no, it has to be amitriptyline. Absolutely stupid.
Yeah,
sorry.
It's weird.
I hope you're listening.
Yeah. Another question from the audience. Have you seen cases of uncontrolled hypertension leading to headaches? And if yes, what do you think the pathophysiology behind that is? And I assume the treatment would be treatment of the hypertension.
Yes, so excellent question. I actually published in our group, the Northern Manhattan study. That was one of the things we looked at, and we showed that individuals with long duration hypertension and uncontrolled hypertension were more likely to have migraine, and in particular migraine with aura. So there's some population, even though population studies are somewhat mixed, we showed a really nice relationship between migraine and hypertension. And one case I had was a patient that has supine hypertension. So supine hypertension can be associated with nighttime headaches, and it's important to be able to diagnose that, because it's like, as you said, it's nice to treat patients and get patients better. It's I think everyone agrees that if you have a hypertensive urgency or emergency headache, it's going to be common. But beyond that, it's somewhat mixed. But in my clinical practice, I have seen patients that have had hypertension, and then that gets addressed, and then their headaches improve. But that's somewhat anecdotal.
Great. That's all the questions I see. Feel free to chime in any last minute questions if you have any, team. Otherwise, I think we're all set.
Okay, awesome. Well, thank you for joining the 8th AAN Virtual Resident Education Lecture Series. These are recorded and will be available through AAN YouTube and AAN.com. The next lecture series date is December 9th on cerebral palsy. So look for the Zoom link on AAN social media channels, but otherwise, thank you so much for joining us today.
And if I could just put a plug in for the American Academy of Neurology and all the great work that they're doing, first of all, for this resident lecture series, Dr. Weber, this is amazing. But there are a lot of other resources available in the American Academy of Neurology. We have the Neurology podcast. If you're interested in headache, we have a lot of really fascinating interviews on headache and the various types of headache disorders. We did a whole Thunderclap series just recently that it's freely available. And then there are these resources that are available for approaching patients with both headache and migraine and how to document. Because once you do this well, then there's a lot of power in really trying to get your patients the right treatments and therapeutics and getting them better. So thank you.
Yes, thank you so much. Have a great rest of your day, everyone.